All right, well, I will go ahead and get us started. So welcome everyone. Today is May 29th, 2024. This is Johns Hopkins Physical Medicine and Rehabilitation Grand Rounds. And we are excited to be welcoming Dr. Jason Falvey. Dr. Falvey is a physical therapist and clinical scientist. He completed his doctorate of physical therapy training at Husson University in Bangor, Maine, and received a PhD in rehabilitation science at the University of Colorado. He also did a 2-year postdoctoral fellowship in epidemiology of aging at Yale School of Medicine, and he is currently an assistant professor of physical therapy and rehabilitation science and of epidemiology and public health at the University of Maryland School of Medicine. And he is the inaugural director of the Center for Disability Justice, which leads into today's presentation, where he's talking about moving towards mobility justice, particularly helping older adults thrive after serious injuries, and illnesses. So I will pass the tile to you, Dr. Falvey.
Okay, thanks for that great introduction, and thanks for having me for Grand Round here. I'm hoping we can cover a few varied topics today, but I'm kind of open to drop questions in the chat, or if you have other, thoughts along the way. Like, it's a small group, so feel free to just interrupt and ask. So I've been really thankful to have a lot of NIH funding and PCORI funding to support various pieces of the work that I'm doing. I don't have any other disclosures beyond that funding. And what I really want to talk about today is thinking about this concept of mobility justice. And we'll define what that is and how it applies to how we might want to frame treatment goals and priorities for older adults after serious injuries. So I study geriatric trauma quite a bit, hip fracture, traumatic brain injury, and have done a lot of work with critical illness, and like things that cause serious disability. But these topics are broadly applicable to a lot of other conditions like stroke and spinal cord injury and brain injury that also occur frequently among older adults after falls or other traumatic incidents. And I have a very specific interest in neighborhoods, and especially around Baltimore, there's a lot of diversity of neighborhoods, and some really facilitate mobility and participation in really important life activities for older adults, and some really provide a lot of barriers. And some of that's from physical and social and transportation related environment. And I'll talk about how some of our research looks at those intersections and where we're going with that. So my lab is, we call it the Enhancing Rehabilitation Improved Community Health, or the Enrich Lab. And we're very fortunate to have a lot of great collaborators and mentors along the way here. One of the things we really, kind of have as underpinning is that we focus on newer catastrophic disability, but we're very diagnosis agnostic. We focus on a lot of different conditions. I'm not a orthopedic researcher. I'm not a neuro researcher. I'm kind of equal opportunity around how do we help people get around in the community after some sort of serious illness or injury. And our lens is always equity and justice centered. How do we make sure that everybody has equal opportunity to get around their homes and community in kind of an unrestricted way, which is often what matters most to patients. Like, patients prioritize function and cognitive outcomes even more than, extending their lifespan when they're given the choice. And we do this research, through a variety of methods. We do health services research, traditional work with Medicare claims and Medicaid claims, or large survey data. We do qualitative, we do epidemiological studies where we work with cohorts and link other data to cohorts to really understand, intersectional identities and how, disability intersects with, sex or gender, how it interacts with, race or ethnicity, or by neighborhoods. And we're moving towards developing home and community-based interventions that are co-developed with members of different neighborhood communities, or co-developed with patient and care partner groups to really make sure that they're meaningful and translatable and generalizable to the actual needs that patients have. So I always start with kind of a off-the-cuff question in these presentations. And I ask this question as a way to frame the importance of mobility justice in neighborhoods and communities. And So maybe I'm just going to open the floor up for a second and make people participate. You can stay off camera if you're eating your lunch like I was 10 minutes ago. But what do you think, to your mind, best defines the presence of a civilization? Like what would be the things that would be like, this is a civilized, civilized community? Thinking historically. And just throw it in the chat. I teach a lot. I'll wait somebody out to put something in there. Order. Okay. So what would that look like, Martha? Put her on the spot. But things like order come up, people that follow rules, some sort of like, there's written norms and cultures, there's written word, written language, right? There's like a formal way to communicate, social structure, hierarchy, leadership. Yeah, all of those things are, the traditional anthropological answers. One of the things that anthropologist Margaret Mead, or like at least she's credited with saying, she's gone through some of these types of things. These are answers that often come up. But Margaret Mead actually said the presence of healed fractures among members of a society is actually one of the best signs of civilization. So if you have a healed femur fracture, that means that after you broke your bone, that you had a community of people that brought you food, that protected you from other predators or other animals, that helped you get around if your community was mobile. They helped you deal with symptoms and comfort, and they helped make sure you got the medical care that you needed. So Margaret Mead said the presence of healed fractures in a society is one of the best signs of civilization, because it was the community coming together for the common good, and doing this for to make sure that you got to maintain your participation in society. So the thing she pointed out here, that community is really needed. A strong neighborhood and community culture is needed to really address these serious disabling conditions. And that's really well aligned with the priorities of older adults with a disability. Many of them want to be able to continue to age in place, which often in the literature is they're alive and living at home instead of a nursing home or other facility. And while that's good and that's important, it's not necessarily sufficient. So unrestricted participation in social activities is also something that older adults really highly value. We're not as good as a rehab group, at least from physical therapy side, we're not as good at really making this our end goal. We talk about it a lot, but when we match it up with what we expect people to do in inpatient rehab or skilled nursing facilities, it doesn't necessarily match up. 150 feet to get a max score on the FIM doesn't necessarily match up with what people need to do in the community for unrestricted participation. So high quality aging in place takes both of those things. Home but homebound isn't good enough. And it has a lot of factors that go into that. We're pretty good as a therapy community and a rehabilitation community at addressing strength and walking ability. Those are impairment level things we're really good at. We're not so good at thinking about neighborhood and social kind of barriers to that function, which is often disproportionately impacting the most vulnerable members of society. So mobility justice, or the underpinning of what we do with our lab here, is really thinking about how to make sure all individuals feel safe and have the freedom to move around freely in their home and communities, regardless of their identity. So for many of us, that is working with people that are newly disabled, maybe new primary wheelchair users. And then often those new primary wheelchair users may live in neighborhoods that aren't as safe to be able to use those wheelchairs, broken, cracked sidewalks, or from a crime and safety standpoint, or they're living in, communities where they are racially minoritized or, minoritized on the basis of sex or gender identity. So these are all things that are what we think about as disability justice, but we really focus on, the ability to get around your home and community. And this is important because life space mobility in general is a really good marker of high quality aging in place. Like how far, how frequently, and how much help you need to get to these different areas, from bedroom all the way into your town, or unlimited, being able to get on a plane and fly somewhere. It's a huge marker of how high quality somebody's aging in place really is. And we often stratify that into community or non-community levels of mobility. And this is important because older adults have pretty high demands in terms of things that they actually want to do. Like the media stereotype of older adults might be they play mahjong in their nursing homes, but 14% of older adults have goals. Their favorite activities is walking and jogging, or doing outdoor maintenance, being able to fix their lawnmower or fix their cars themselves, or playing sports with their grandkids. These are pretty highly active activities. When we think about how far older adults have to walk in the community, to walk into a hospital to visit somebody, and you guys probably know, is having to park somewhere and walk, a long ways, and getting on shuttle buses to get, to and from different sides of the hospital. You could walk up to 750 meters. And for those of you who are, not so good with the metric system, that's a lot of feet. That's like 3 times as many feet. And we got to compare that to 150-foot goals that are often common, in post-acute or home healthcare for older adults. And, I've been guilty of having these 100-foot goals when I was a home care therapist. And that was kind of the unwritten benchmark for when somebody wasn't homebound anymore. But it didn't really let them do these kinds of things very easily. So huge disconnect already in terms of community mobility demands for older adults, and how we set them up for success. But the problem isn't necessarily just that gap. The problem is that the gap disproportionately impacts people who need community mobility the most, like our patients in disadvantaged neighborhoods who have to walk to get their groceries 2 or 3 blocks at the neighborhood store and don't have access to other transportation. So when people lose the ability to get around their home and community in an unrestricted way, these are usually people who are, have restricted activity, have a fall and got a little nervous or fear of falling, or, get sick and don't have to go to the hospital, but have some symptomatic, reasons that they restrict their activity. But really, hospitalization. Once somebody's hospitalized, it's over a 600% increase in the risk of them losing their ability to either walk or drive in the community. And that really ultimately makes this life space shrink. And when life space shrinks to this level, when you're not leaving your bedroom or your home as often, it really increases this risk for social isolation among older adults. And the current gaps in our rehab care that really drive this, like we talked about, we don't necessarily get patients outside and have them practice over these environmental hazards. We don't have functional outcome tools that our insurance companies really believe that are valuable, that have distances over 150 feet that kind of drive payment. In home healthcare, some of those same issues come up with the fact that they also have to be homebound. So we don't walk people as far, or don't practice getting on public transit with people, because then they would not be considered homebound, but they actually still can't go anywhere, even if they complete home care successfully. And then outpatient care is hard to get to. It's expensive to park. It's, not often done in a way that is one-on-one in a lot of clinics. So these are all the barriers that kind of lead into why shrinking life space, social isolation, and we don't have a good way to reverse this when it happens. And the way I really summarize this in terms of just like big picture for our policymakers is that squats don't address these social determinants of health. So just doing exercise with people doesn't help them independently overcome some of these neighborhood barriers. So community mobility, clearly important for older adults, and it disproportionately affects people who are, in minoritized identity groups. So with community mobility, this is concerning because nearly 1 in 5 older adults can't walk 2 or 3 blocks outside. And if you took away their device, about 30% of people wouldn't be able to do this. So this is work from our group and then some historical literature. And 1 in 10 older adults who are able to walk 3 blocks now won't be able to do it a year later. And there's a lot of factors that drive that, but still 10% of older adults, every year lose the ability to walk 3 blocks in their community. When we do this trends in national data, we can see that it's pretty persistent. It really hasn't gotten better from 2015 to 2020. We've had a lot of improvements in markers of cardiovascular health. We haven't really moved the needle much on getting people out in the community very much. It's not a big public health priority, but it should be, because there's massive inequities in the trends in community mobility among older adults by racial and ethnic identity. 4 in 10 older adults who identify as Black aren't able to walk 3 blocks in the community. And that's less than 25% of the same older adults, similar matched, who identify as non-Hispanic white. So clearly there are racial and ethnic gaps in community mobility that are not just persisting, they're getting a little worse over time, to be honest. And that's not been on our radar because it's not heart disease or stroke or other things that we have had a lot of public health interest on. So we have a lot of people living longer, but clearly not able to get out and engage in the community. Major missed opportunity. So when this happens, when people lose the ability to lose community mobility, it's not just a quality of life thing. They're 3-fold more likely to die over the next year. They have 22 more hospitalizations, and they have limited ability to access public transit and visit family and friends. You're also less able to relocate during disasters or public health emergencies. So, being able to, quickly go to a son or daughter's house is really difficult when you're limited in community mobility or being able to get somewhere safely. And it all adds up to increasing disability, needing more caregiver support, and ultimately increases your risk for nursing home admission. And like we said earlier, it definitely brings up the specter of social isolation and loneliness. Not being able to leave your home, not being able to go out and socially engage is especially concerning when older adults might not have other connections that are virtual or via internet with family and friends. So we often frame this conversation about neighborhoods in a resilience context. So this resilience framework, kind of talks about cognitive, psychosocial, and physical aspects that help you stave off declines in function. So you have a stroke or you have a hip fracture, the higher your resilience is before that injury, the less likely you are to experience persistent mobility declines. But the really important piece is this exposome piece, which is the neighborhood and social environment where people live. And that affects, intersects with physical, cognitive, and psychosocial health. And it's something that we can do a lot about, but we often don't screen or address some of those specific barriers. So it makes our efforts that are improving their physical function, we can do that. We can give them lots of exercises, get somebody a lot stronger, but they don't really address their neighborhood barriers. So you end up like this person. When you address all those neighborhood barriers, if you don't address the neighborhood barriers, but you get this person really strong, but their sidewalks are still broken, it's still going to make it really challenging for that person to get around, even if they're quite a bit stronger. So we've also complemented some of the background work we're doing. We're doing qualitative work where we're asking patients about these specific neighborhood barriers. And we're asking people about experiences with services that are supposed to help overcome this, like paratransit use, and how those services or lack thereof are really helping them get out in the community and engage. So I'm going to share some quotes from these studies along with some of the other objective data that we have, so you can really kind of anchor what this really means from a lived experience perspective for these patients. So when we talk about how neighborhoods impact mobility justice, how do neighborhoods impact people's ability to equitably get around their community and engage in social activities? There's kind of 5 components that we really talk about here. It's social cohesion, like, do your neighbors band together? Do you have a social support network? Does the built environment support you being able to get around? Do you have access to transit to be able to get, and transit that accommodates your needs? Is your neighborhood investment in terms of lights and street safety and, picking up litter on the sidewalks that impedes walkability? Is your neighborhood socioeconomic status and resources? And then neighborhood safety, in terms of crime and violence and pedestrian safety. There's patients who don't cross certain streets in Baltimore using a walker because people drive like, quote, bats out of hell. And we'll talk about kind of what that means in terms of mobility. So we'll start with social cohesion. And this is really the concept of like strength of relationship, solidarity among members of a community. That's the CDC's healthy person definition. I think that's pretty clear to us that these kind of communities are vibrant. And don't mind the ChatGPT generated artwork in the middle. It does a nice job, doesn't do so good with text. So if you live in an area that people don't trust each other, they don't think they can count on each other in emergencies, they don't think that there's a lot of connectedness, there's actually 35% lower likelihood that you're going to be interacting regularly with your family and friends. And when this happens, your social isolation risk continues to increase. Community mobility is also really problematic in socially non-cohesive neighborhoods. If we just look at these trends in community mobility we looked at earlier, people that live in socially non-cohesive neighborhoods or neighborhoods where there's a lot of distrust, they're 1.5 times more likely to not be able to walk 3 blocks. And that's after accounting for some of the age and sex differences of people and health differences in these neighborhoods. So that's really driving some engagement and out-of-home activity. And when you don't have social support, social connectedness, you're kind of cut off from family and friends because you can't get out and engage, this really has an impact for people after serious illnesses and injuries. You've probably seen it after stroke or spinal cord injury when there's a lack of a support network. It can really limit the recovery. And for older adults, nearly 1 in 4 are socially isolated, have some element of social isolation. They would meet the criteria of not having a live-in partner or spouse, or not having routine connections with community, family, or friends. We've looked at this also for people with high levels of disability. If you have social isolation before you end up in the intensive care unit and are critically ill, a situation where we know people end up with a lot of downstream functional disability. And we looked at data where we had pre-admission social isolation and looked at just, are those patients more likely to die or have increasing disability over the subsequent year? And so this paper that we published in JAMA Internal Medicine a few years ago really found kind of a dose-dependent effect. Like, as people became more socially isolated, their survival probability decreased really significantly over the course of 1 year after their intensive care unit stay. It really ended up being more than double the risk of death between the most and least socially isolated groups. And clear that even small increases in social connectedness could confer a pretty good survival benefit. Now, when we talk about disability, which patients often prioritize even more, the gap between where somebody's disability level started and where they ended grew at every level here. So as their social isolation increased, their disability levels increased after the ICU, even after accounting for where they started. So it really made it about a 50% higher disability burden between the most and least socially isolated. So social isolation definitely is not just a quality of life concern, but it really confers some real risks to patients for a variety of reasons that, probably we could spend a whole hour talking about. But this is why community mobility is an important marker, because it starts to identify when these people are at risk for social isolation, when they're disconnected, when they're not able to engage with the community. So when we have this good socially cohesive neighborhoods, it might buffer the effects of hospitalization and reduce life space mobility declines. And it might also help facilitate improvements in functional recovery. When we've talked to our patients, they've said, when they live in really valuable neighborhoods or like with high value social currency, they're saying, yes, my neighbors would help me get around because they do like little things. If my shoe's untied, they come and tie it for me and stuff like that to make sure I don't trip, because that's happened. And if I need a little help coming in the house, if I have too many bags, they're very helpful. I live in a big building with lots of people, so someone is always there to help. So that person is able to go out and do more mobility challenging things, is not afraid to be independent trying to grocery shop because she has a social network of people who are willing and able to help. Even somebody coming out to tie her shoes so she doesn't fall. This is a community looking out for each other. So social cohesion is one important part. Transit access is the next. So you can get around your neighborhood by walking, but often to get to medical care, to get from West Baltimore over to Johns Hopkins to get treatment, you usually have to, take a bus, and usually 2 buses to get over there. Our work that we've done in the Journal of the American Geriatric Society suggested that upwards of 10% of people who live in cities that are older adults are regular public transit users, have used it at least once in the last 30 days. 600,000 older adults in the US use it as their primary way to see their doctor. Also, very, very important, because we don't often assess people's ability to do this outside of some very specialized settings. So transit use has a lot of drivers, and people that are more medically complex are less likely to use transit, but neighborhood factors like having broken or cracked sidewalks near your home was associated with 65% lower odds of transit use. And things that maybe we as PM&R people aren't as surprised by is using wheelchairs. Also, a very big negative driver of using transit. And then unable to walk 3 blocks. People that can't get to those bus stops, there's not a lot of accommodation for them. Like paratransit doesn't clearly bridge that gap. So there's a lot of contextual factors here that drive transit use. So if you can't walk 3 blocks and you can't take the bus, you're probably stuck in your home and at risk for social isolation. And 20% of older adults in some urban areas, and this Clark study with Chicago, had to walk more than 500 meters to access fixed route public transit. In New York, if you lived in the Bronx, you might have to walk up to a mile or wheel up to a mile to get to a transit station that had an elevator. When we talk about where transit is available in Baltimore, it's available most where people don't actually use it. Most people in West Baltimore and East Baltimore rely on transit a lot, but that's where there's the most need, right? This red is kind of this the low transit density, or really critically low infrastructure for public transit. But statistically, this is where most people actually rely on transit to get to places. So they have to walk further to get to stations, but they're also getting less care. We're not focusing on community mobility as part of our rehab process. So these patients are disproportionately kind of paying the toll for that oversight. Even increasing transit access a little, communities that invest in transit access might spur increased mobility function. So a study done by Erica Twarzak, who is a fellow in the Center on Disability and Health over there at Hopkins, she took a look at if the density of public transit stops was associated with older adults being able to get out and walk for exercise. and how much of that was explained by making it easier for them to use public transit use. And she just found that 32% higher odds for older adults that lived in high density public transit, stop areas. And, a quarter of that association was actually like people were uptaking use of public transit and they were walking more because of it. So advocacy, neighborhood investment, or, screening and identifying where these gaps might be could help figure out what we need to do to help older adults participate in physical activity and be able to access transportation a little bit easier. And in the UK, they've done studies where they give older adults free bus passes and just say, here's a free bus pass. And if you do that, they use public transit more, not surprising, but they're also more physically active just because they're walking more places, making it more accessible, increase their quality of life, and also reduce depressive symptoms. So simple things we can do at the city level, helping people get access to transportation, whether that's, through programs, helping with mobility link. These are high value things that we and PM&R often do more. I know in my clinic, at the Veterans Administration, I do a lot of filling out mobility link applications. And for this reason, because I know people that can get out more freely and be able to participate in society, it might actually improve their quality of life. So being able to get out and walk in your neighborhood and get to the bus really depends on having a high quality built environment. And the high quality built environment is really thinking about buildings, streets, open spaces, or lack thereof, right? So lack of green space, for example. If you live in a neighborhood that kind of looks like this, which is a real picture of Baltimore, if you live in this neighborhood, it has a lot of broken, cracked sidewalks, curbs, discontinuity, a lot of random places where the sidewalk just stops. You're 4.5 times more likely to not be able to walk 2 or 3 blocks. And when you live in a neighborhood like this, not surprisingly, you have a 27% increase in the odds of being a recurrent faller as an older adult. Other deterrents for getting out. When we talk to patients, they're also thinking about the built environment in terms of traffic safety. So one of my patients, and this resonates with me really deeply because I live just on the other side of Martin Luther King over here in West Baltimore. And she told me there's another thing I don't like doing. I don't like crossing a bunch of streets. Maybe 3 or 4 years ago, I would cross Martin Luther King, but I wouldn't cross it today if my life depended on it. And I asked her, why is that? There's too much going on. They drive like bats out of hell. They drive like they on the highways. I'll be scared. I'm scared half to death to go across Martin Luther King. And earlier she had mentioned that she uses a walker on a regular basis. Fast light cycle, walker, dangerous street conditions. These are things in the neighborhood that, there's a lot of urban planning pieces that you could do to make it more friendly for people living with disabilities to get around. And these are the kind of stories we need to have. We ask other patients, and another gentleman told me that there's lots of streets in the inner city that aren't put together. So that could be fixed to make sure we have pavement. That's how I hurt my knee from the beginning. But I was in another city and it was uneven pavement. I twisted my ankle, and before you knew it, I tore my meniscus and I've had pain ever since. So we're compounding, pain and swelling in a knee with another injury and mobility issue this person had, and direct consequence of living in a lower quality built environment. And those often don't happen randomly across neighborhood environments. They often happen more in the neighborhoods that are chronically disinvested. So disinvested communities, have fewer economic resources and limit opportunities to receive preventative and restorative medical care. That's really important in terms of access to healthcare for many of our patients with new disability, so for they have a lot of medical follow-up appointments or need to, receive a lot of rehabilitation. And these lower, socioeconomic status neighborhoods are chronically disinvested, have fewer investments in green space, so less park space for people to be able to walk safely, have fewer community events and resources around, and infrastructure like community centers or other places for gathering that limit opportunities for social engagement. This has a big influence on both resilience, recovery, but also cognition. There's a great group out of University of Michigan who has mapped different aspects of neighborhoods and linked it to the average cognitive levels of people and their rate of cognitive decline of living in those neighborhoods, and really kind of boiled down to things like having organizations and a lot of social connections, restaurants, cafes, having museums and libraries, and having rec centers or parks, all are associated with higher baseline cognition and greater maintenance of cognition over time. This cognability, and neighborhoods that are the hazards that are more common to disinvested communities, like fast food, highways that gonna go across, and either people have to cross in dangerous places, or they have to walk around traffic, or they have to cross at go up a flight of stairs and cross across a bridge that might be very difficult or kind of scary for somebody who has limited mobility, or polluting sites, places where there's high amounts of air pollution, factories that have smells or make the air quality poor. So people with pulmonary disability would often struggle to get around. So these are really important factors around neighborhoods and how they directly drive some of this, cognitive recovery, resilience, and opportunities for getting around. We often measure this neighborhood disinvestment kind of formally with an area deprivation index. So in Baltimore, not surprisingly, we can see at the census block group level, so each individual neighborhood where these little lines are is a census block group of 600 to 3,000 people. And each one of those has its own area deprivation index score based on income, education, employment, housing quality, car ownership. And it kind of matches what we are gestalt about Baltimore, where West and East Baltimore have chronically been disinvested, and then this strip down the center, in the Inner Harbor and Harbor East and Canton, Fells Point, and into Locust Point are all relatively advantaged. Areas around the middle of town, Mount Vernon by the train station, are a little bit starting to be on the fringe, and then as you get kind of to the west and east of that, it becomes very disadvantaged very quickly. So of course that's a measurement of very specific things. It doesn't tell you everything about a neighborhood, but when we look at how that associates with health outcomes, we get a lot of clues into how it might impact function and recovery. So older adults who live in these type of neighborhoods are more likely to spend a higher percentage of their remaining life living with an ADL disability. So this is work I did with my mentor at Yale and others, where we looked at people who lived in disadvantaged neighborhoods at every age group, starting at 70 all the way to 90. And we looked at the percentage of their remaining life they'd be living with an ADL disability. And this was measured monthly. This was a very unique data set where people were called monthly for a period of over 20 years and asked about their disability status. And as you follow people across every age group, and even after adjusting for a wide variety of covariates, people that lived in consistently disadvantaged neighborhoods or disinvested communities spent a higher proportion of their life with disability. So suggests there's a lot of unmet needs for patients living in these areas. Work that we've done with critical illness survivorship has found something similar, that immediately after a critical illness hospitalization, you follow people for a year, and if you live in the most disadvantaged areas, in the worst 25% in terms of investment from, in terms of disinvestment, then chronically you had, on average, 10 or 15% higher disability burden over 1 year. And that might only work out to the difference of one ADL on average, but that's one ADL more that you need human assistance with. which could be bathing or showering, or you lose the ability to drive independently or walk in the community independently. So those are all things that are really meaningful to older adults. Work that we're doing now that's under review is we've also looked at from COVID-19 and people recovering from a serious COVID infection that were hospitalized at Yale New Haven Hospital, and we followed them for 6 months. And we looked at people who lived in the red, the highest 10% of neighborhood deprivation. And they persistently had higher symptom burden, immediately after their admission, and then consistently all the way through 6 months. So there's a lot of vulnerability that these patients have to illness in terms of exposure to chronic stress, kind of makes them more susceptible to more severe infections. And they clearly have persistent gaps in symptoms that either stay the same or worsen over time, compared to people in the less deprived areas. And when you control for things like, illness severity, where, if you look at the ICU measures of illness severity, they're almost identical in terms of the severity of their underlying illness. The patients in the red are actually younger and have similar amounts of comorbidities, but yet they still have persistent symptom burden that's worse over time. So these long COVID symptoms that we know are persistent and troubling really disproportionately impact people in these neighborhoods. When we think about the intersections of neighborhoods with other geriatric vulnerabilities, we think about things like frailty and multiple comorbidities. People that have a lot of needs, like older age, multimorbidity, hospital frailty risk score that's higher. If you combine that into a measure of geriatric vulnerability, which one of my collaborators did in a paper we worked on together, and took a look at people undergoing emergency general surgery, which is another highly disabling, surgical condition. And we looked to see if people were more vulnerable at baseline, were they disproportionately more affected by living in a high ADI neighborhood in terms of their surgical outcomes. And what we found was that if you lived in the lower deprivation neighborhoods, you had you had 6 times higher risk for 1-year mortality if you had a high degree of geriatric vulnerability. But if you lived in a high deprivation index area, so if you had very high disinvestment in your community, having that same amount of geriatric vulnerability was 15 times higher risk for 1-year mortality. So it says that there's amplifying effects of neighborhood that disproportionately affect the more vulnerable in our population. So when we think about people living with disabilities who are already a vulnerable population, they're more likely to live in disinvested communities. They're uniquely vulnerable to not just mortality, but also declines in function, cognition, and community mobility, and at risk for social disconnectedness. We also use Medicare data to look at this, and we've built this model of days at home based on Medicare data. So this model's kind of been around, it's been developed as a population health measure, but we really have this days alive and at home measure that we have on people monthly before and after their hospitalization. So we know from Medicare claims where somebody is on any given day. If they're in a nursing home, if they're in an inpatient rehab, if they're in hospital, if they're in the emergency room, we can combine all the files together and we look at how many days they weren't in any one of those facilities. So in that case, we know that they were at home. And we do some statistical modeling to account for the fact that people in those neighborhoods might be more likely to die each month. So we kind of weight for that probability. So we're looking at real differences by neighborhood and not just who's going to die quicker. We asked Medicare for 9-digit zip code so we could link every beneficiary to an area deprivation index, so this deeply phenotyped neighborhood level, and then adjusted for all of the factors that we would think are relevant. And we really wanted to see, does neighborhood deprivation matter on a population health scale? Not just in these regional samples that we had, but on a population health scale. And what we found was in our preliminary data here that a month before a hip fracture, that no matter what neighborhood group you were in, you pretty much spent around the same number of days at home. It was on average about a half a day difference on a population scale. And you're spending close to all of them at home. But if you're in the poorest 15% of neighborhoods over the course of a year, you ended up spending what accounted to about 20 more days away from home after hip fracture. And this exceeds both the statistical minimally clinically important difference in the general older adult population, and also what patients perceive as the minimally clinically important difference of 7 days. When patients are asked how many days at home, worse for one treatment versus another, would it take for you to think that one's better? And they're like, 7 days. That's what patients in some recent work have really settled on, is that's the most likely piece for them to agree on, is that 7-day time period for both patients and care partners. So 20 more days away from home after a hip fracture is really, really large difference, especially if it's just on the basis of neighborhood. And we haven't even started looking at intersections of other vulnerabilities. So I think that's definitely research that we'll be developing here over time. And of course, in these disinvested neighborhoods, there's a lot of concerns about healthcare quality. On average, there's lower quality home-based and nursing home care that are located in these zip codes. That's on average across the United States. If you live in a high poverty zip code, you're generally more likely to get lower quality SNF care. And if you're receiving home care from an agency, the readmission rate of those agencies is higher. They're also much more poorly staffed. So work that we've done looking at staffing in nursing homes based on neighborhood disadvantage shows major differences in terms of, just registered nurse, CNA hours, and across all the rehab disciplines, and number of hours per resident day that are worked, and just on the basis of where the facility is located. And this is after accounting for, medical complexity of the residents. So this is the same medical complexity of residents, but if you are in a low income zip code, you're much, much more likely to be served by 5 fewer nursing hours in a 100-bed facility, 2.5 fewer CNA hours, and then, 1.5 to 2 fewer hours of PT, OT, PT assistant, OT assistant. You add that all up, and that's a lot of people, hours that are reduced for people just on the basis of neighborhood. So that's really concerning, and we've done other work with antipsychotic prescribing that shows that this has really big implications for the quality of care people are getting in terms of the amount of antipsychotics that they're getting in those facilities. So when we ask about the impact of neighborhood investments and socioeconomic status, patients just say things like, the community's no help because all the carrying's on going on. The store that's close to me has closed. I'm looking at a store that's even further away that I have to get to. So yeah, what's in my community, and we were talking about community resources, is definitely affecting my surgery and my recovery to an extent. So even something small like, disinvestment in a community that doesn't allow local businesses to stay open, or crime that, doesn't allow people to easily get to these stores, it has an impact on recovery because patients can't be as independent going to get things like groceries or going to the pharmacy. And it takes a toll on their recovery. So neighborhood safety, I'll close with quickly, and I know we'll leave a couple minutes for questions, but, both actual crime in your neighborhood and what patients think of the crime in their neighborhood affects health and wellness. And if you live in an area where you don't feel safe, you're more likely to have functional decline and walk less. Not surprising. And this is concerning too, because high crime affects delivery of healthcare. The home healthcare workers and other home healthcare staff are really directly affected by high violence in certain urban neighborhoods. Very understudied, but concerning. And so we ask patients about going out later in the day. Why do they have to restrict their hours for walking in such a narrow window? And just people are fearful of guns. You know how Baltimore is. I'm fear that, I just don't know. It's the first time I've ever lived in Baltimore my whole life. So coming to a new city, having a perception that the city is unsafe really is problematic in terms of, being able to independently be mobile in the community, and might restrict your activity in ways that physical therapy and our exercises don't really affect. And so we ask patients about, to other pieces about access to resources, and stores 2.5 blocks away, and I can't walk that distance. I'm really afraid to walk that much because the goings on around this block, there's been shootings, there's been robberies, there's been gangbangers. I'm not in a position where if I was to go out there and if something happened to me, I would be a sitting target. There'd be no escape for me. So the specter of gun violence definitely impacts mobility for our older adults and getting out in the community, but we don't really have much in place to really help. So we really need to understand where people live in terms of, their resilience to functional decline and their opportunities for functional recovery. And this is especially important for people in minoritized communities because they are disproportionately relying on things like public transit or walking to get places. They don't have personal vehicles at the same rate that other populations do. So that's really the overlaying concept of mobility justice. Not just can we, get people moving, but can we set up the system where, recovery is equitable. So if we're moving in that direction, we really have to think about, as clinicians, like asking these questions. PM&R, I think, is actually really good at this, like thinking about how did you get here? And I have patients with balance issues that tell me they took public transit. That's terrifying to me. And I immediately start looking for how we can bridge those gaps. Asking people what's making it difficult to get to the store or pharmacy, and or your clinic have specific neighborhood resources to help. And then what would make it easier to get around? Patients often know what they need. Whether we can get it to them is always a challenge, but we can involve our home health care or social work colleagues whenever we can. And we obviously need more tools as researchers. And this is something that I'm thinking about, is how do we measure community mobility in a way that's actionable for policymakers and really bring some of this to life. And then advocacy. Some of our academic platforms are powerful, and I've tried to use some of the new resources that we have access to, and others to be thinking about intersections between disability and these efforts. And thinking about DME policy, social support networks, and thinking about policy things that we can do in terms of increasing funding directly to these areas. And I'm going to skip over what we're working on because I think I want to leave a couple of minutes for questions. But we're working on some interventions in that space to bring together all those pieces. And ultimately, we try to move our interventions towards justice. How do we fix the system so people don't even have to ask for what they need? It's just there's pathways for them to be successful. So we really have to care about community mobility and think about interventions that don't just get people stronger or address their tone and spasticity, but also think about how do we address the contextual factors. So I apologize. I know we went kind of right towards time, but I'm happy to take a couple of questions, or I'm also happy to leave my email and people can follow up with me. These virtual ones are always hard for me to keep track of time, but I appreciate you jumping in, and hopefully that was at least some nugget of knowledge that you could take with you. All right. Let's see. Megan put something in the chat. Hi, Megan. Good to see you. Thank you.
Hi, good afternoon. This is Preeti Raghavan. It was a great talk. Really appreciate it. So you clearly wrote down, mentioned the huge mountain of challenges that many of our patients face. When they have a disability, it just compounds, right?
Mm-hmm.
So, we've been really trying to address some of these social determinants of health barriers, to get our patients with new disability back to the clinic. Do you have any suggestions for other resources that we may avail of? Because, the biggest barriers we face here, particularly for the population at Johns Hopkins, is these social barriers.
Yeah. So, and we experience a lot of the same barriers you probably do on the west side here with a lot of our patient population. And so we have a couple of suggestions we've made from our rehab side. Is one, like, try to think about clinically creating care pathways that allow some home-based care. So like home-based outpatient care would reduce a lot of the restrictions on like homebound status and payer. And you could, create care pathways where your highest risk patients have opportunity to have a clinician come to them, kind of reduce the burden of getting to clinic, having some home visits, trying to bridge virtual gaps when you can, trying to be able to create opportunities for those things. It's very difficult when things like prosthetics and wheelchairs need to be adjusted, and those things have to be done in clinic. And then from a research side, we've thought a lot about, like, how do we not just give somebody a bus pass to come to and from our clinic, which is 3 hours to wait on Mobility Link on either end of an appointment, but how can we find other ways to, get people to and from a little bit more efficiently in ways that facilitates them attending. And then we're developing models of care where we actually go in the community and specifically work on these social and neighborhood barriers, have targeted rehab and peer support to actually like walk with somebody to make them feel safer, and physical therapy specifically to work on getting on a bus or public transit to hopefully open up some of these avenues. So it's not easy, but those are some of the suggestions we've made to our system, and with varying degrees of success, I'll say.
Great, thank you. And so can one contact you afterwards to sort of see, if some of those resources that you're developing could be helpful?
Yeah, absolutely. Feel free to reach out.
Great, thank you.
All right, well, we are at the 1 o'clock hour, so we thank you all for attending. Dr. Falvey, thank you for a wonderful presentation. And as mentioned, I'm sure he'd be happy to touch base if anyone wants to reach out to him on their own. Otherwise, everyone have a wonderful day.
Okay, thank you.
Bye.